Diagnosis is the most important part of any orthodontic treatment, whether it is preventive orthodontics or corrective orthodontics. If you are watching this video, I am sure it has already appeared in your office. There is a patient with 5, 6, 7, 8, 9 years of orthodontics, and you look at the occlusion and think, my God, they did absolutely nothing. And obviously, there are these professionals who lack training, who did not take a good course or did not take any course at all. But there are also those professionals who go through good orthodontic training, diplomas, specialties, yet still cannot gather all the information to develop a method for diagnosis in orthodontics. Gentlemen, I can place a lot of photographs here where you can see cases that have already come to me, or you also have a lot of cases where the diagnostic method was wrong or not even done. And that is why I am here in this video today to explain to you the diagnostic method that I use, which my students from the Interceptive Formula Diploma also use, and that more than 100,000 doctors have already learned about this diagnostic method, which is the Foca Method. Dear ones, the Foca Method is a method that I developed myself. In truth, for me, when I started my orthodontic care, I had already completed a residency in preventive interceptive orthodontics at the hospital here in Brazil, the Hospital for Rehabilitation of Craniofacial Anomalies. And I would stay at the hospital studying morning and afternoon, and at night I would attend to my patients. And I was immersed in the world of orthodontics. But even so, I was not able to obtain clarity to make my preventive orthodontic diagnoses 2001. So I created the Foca Method. It was a year filled with difficulties, with poorly executed cases. Yes, I have had and still have difficult cases where I have to go through and study to know how to resolve them. But the Foca Method ended up being a problem-solving method in my mind and makes sense to many, many people. And surely Yusin helps you a lot in his office. Maybe you have a specialist file. That will help you a lot in solving the more complex cases. Or maybe you are a beginner, starting in the world of orthodontics. That will change the way diagnosis is made. Before we start, I want to go over the 4 points: facial analysis, occlusal, cephalometric, and anamnesis. We are going to discuss all these points, so let's go to our points of this video. Stay until the end because you will see how it will clarify many things. We start here by talking about facial analysis. Facial analysis is almost something new because it became popularized in the 90s with the analysis of Arnick and Bergman, which is an analysis that I personally love, and became a very strong foundation for creating the focal diagnosis method. Arnick, Bergman, and Andrews' analysis were the main sources that I ended up using as the bibliography to set up our step-by-step. And, well, when we enter a slightly more specific analysis, which would be the evaluation of facial patterns, I have to inform you about this differentiation that exists in facial types, which are the 3 types you already learned in your undergraduate studies, such as mesofacial, brachyfacial, and dolichofacial, which relate to the width of the zygomatic area with the height from the eyebrows to the chin. So we have the dolichofacial, brachyfacial, and mesofacial types. That would be just facial types. But what you need to make a good diagnosis of your patients is the differentiation of facial patterns. Basically, anyone in the world, right? Anyone you are going to visit, any place in the world, is divided into 5 facial patterns. Pattern 1, 2, 3, short face, and long face. Pattern 1 ends up being that patient who has no skeletal problems and has their malocclusion. Pattern 2 is a patient where we visualize an increased convexity that is due to a mandibular retrognathism or a protrusion of the maxillary region, also being a combination of the two. Pattern 3, the reverse, mandibular prognathism or maxillary retroposition, or the combination. And the short face and long face are patients where there is deficiency in the vertical sense. So it is either very vertical or very horizontal. And I bring you here a very interesting article by Dr. Capellosa, right? Where he talks about this differentiation between facial analysis and occlusal analysis. That is why it is important for you to perform a facial analysis on your patient, because what arrives at the party is not the lateral cephalometric X-ray, but the face of your patient. So, of all the diagnostic criteria, facial analysis is the most decisive in the game. The first thing you should do when the patient arrives at your office is to perform a facial analysis to assess if there is lip balance, if there is any skeletal problem, if the nasolabial angle is appropriate, if we have a labial sulcus that is shallow or deep, if we have an adequate chin neck line, a good chin neck angle, we evaluate the proportion of the facial thirds, and we assess the anterior or posterior relationship of the lips. All of that is part of the Foca method in relation to facial analysis. And here I want to present to you a very interesting table from this same article that correlates pattern with dental class. If facial pattern is not related to in any way, or can indeed have something associated with dental class, but not necessarily at all. Observe here this table that will appear for you. Patients from the sample of this article, pattern 166. Patients, that is 47-48, almost 50% of the patients had class 1, but only 50% of the patients who were pattern 1 had dental class 1. The remaining 20% had class 2. 5% had class 3, and there is a total of 97 patients. Now, patients with pattern 2. A patient with angular retrognathism, this patient can also present a class 1. Look, 8% of the patients, the majority will present class 2, a small part class 3. And patients with pattern 3, the majority will present class 1 and not class 3. So these patients who are pattern 3, the compensations of nature can cause them to present a class 1, and that is why their head sometimes gets completely confused. When you look at the face of a patient who apparently looks like a pattern 3 but has a class 1, calm down, you are not going crazy. It is a characteristic of the patient. The pattern 3 patient can indeed have class 1 or can have class 3. And from the moment we do this facial analysis, move on to our occlusal analysis. First, you carefully look at the patient, even before thoroughly looking at what is inside their mouth. In the past, ancient orthodontics was not cephalometry and dental class. Modern orthodontics is not, my dears. Nowadays, we make a comprehensive diagnosis of our patient, and the first thing is the face, the profile, the characteristics, and then we move inside the mouth. And from the moment we are evaluating the patient's occlusion, what is perhaps important to diagnose? The occlusal evaluation is truly a compilation of a list of treatment goals, the same treatment objectives that you have there. It is very important to write it down on a piece of paper. This exercise of listing our patient's problems is slightly interesting. And now you will also follow a method. And within the occlusal analysis, you will do the transverse analysis, the vertical analysis, and also the sagittal analysis, the anteroposterior analysis. And so we will follow a sequence with that. It is good that we observe transversely in our patients. I am going to share with you a little table, which is a diagram that I love to use to achieve a differential diagnosis. Because within our malocclusions, we have malocclusions that have an environmental origin, and there are also malocclusions that have a genetic origin. From the moment we observe that the patient presents a skeletal transverse malocclusion, the treatment plan goes in one direction, and when it is dental, the treatment plan goes in another direction. Look, here we can have a skeletal posterior crossbite, which can be unilateral or bilateral, but when it is unilateral, we diagnose whether it is functional or true. The vast majority of patients will typically have a functional unilateral posterior crossbite, but as time progresses, the patient can develop a true one. And what are the main differences between these chips? Basically, it is when we have a true asymmetry of this maxilla. It is not common, but it can also happen that we can have a dental posterior crossbite, unilateral or bilateral. And after we evaluate the posterior crossbites, we also have to see that there is the opposite, which would be Brody occlusion, where there is overcorrection of the maxilla, where the lid-box relationship is inverted. Imbrogi bite ends up being extremely rare, about 2% of the population. I don't know if you have seen any case like this, but it is interesting that the diagnosis is made to determine the treatment plan. And well, my dear ones, when making the differential diagnosis between skeletal and dental posterior crossbites, you will mainly evaluate the alteration in the morphology of the maxilla. The norm is for this maxilla to have an adequate parabolic shape. And when we see a triangular aspect, we evaluate that there were effects that are likely environmental to achieve this impact on the maxilla. Look at this case, posterior crossbite. We see that there is a narrow buccal corridor. At the time of the occlusal photograph, which is the main photograph, we see that there is a triangular shape of this maxilla, a deep vaulted palate characteristic of skeletal posterior crossbite. Well, these are the transverse aspects. It can be a posterior lying bite, it can be a Brody bite, but we also have vertical alterations. Our patient may present an overbite, which is appropriate. That would be too minor. And when that decreases to visual, then it goes to the anterior open bite. That can already be considered a malocclusion. Just as when I have more than 2 minutes of overbite, that can be classified as a shadow bite, a deep bite, however you want to call it. But still, all the malocclusions that we have at our disposal, like we have 2 types of etiology. It can be true skeletal, or it can be dental environmental. All of this will depend on the origin of the etiology. And just as the treatments end up being opposite, that's why everything starts there at the beginning in the diagnosis. So look here, multiple deep origins, which can be simple or complex, and the problem can be dental or skeletal. But how do I know when I have a deep bite that is of complex origin? Basically, we go back to our facial diagnosis. When we visualize that the patient's growth pattern is horizontal and is accompanied by a deep bite that is already considered severe, we see the difference between the posterior plane and the anterior plane of the occlusion quite distinct. We also see that cephalometrically, which is our next point, this patient presents a deep bite that is skeletal. So all these aspects lead us down this path, and we already know that this deep bite is much more difficult to treat, and the potentials for remaining stable without residues ultimately are more difficult. Well, look at this horizontal patient, the difference between the posterior and anterior planes, and we see that we have to overcorrect because the masticatory muscles will make it increasingly difficult to maintain stability. Knowing also, my dear ones, that the opposite, the anterior open bite, is also a bad occlusion, which can be of skeletal or dental origin. And so the repercussions of what is happening inside the mouth are already outside the mouth. The skeletal, we see that the patient presents an open glugoniaco, a tendency for vertical growth, absence of lip sealing, and the characteristics of the malocclusion can also be indicative of something skeletal. So see that all malocclusions of skeletal origin correlate what exists outside the mouth with what exists inside the mouth. And finally, my dear ones, you will go to the next step of diagnosis, which is to evaluate the anteroposterior or sagittal aspects. Now, we are going to see molar relationship. Look, as a diagnosis, it is much more complex than just opening the patient's mouth. Only now are we seeing molar relationship. And now you will, of course, classify between class 1, 2, 3, which is the basics we have, but we also have a more complex classification of class 2, which would be class 2 division 1, class 2 division 2, and class 2 subdivision. The subdivision refers to symmetry. So when we have class 1 on one side, class 2 on the other, it is a class 2 subdivision. And it is important to evaluate now because the treatment plan, whether with extractions or without extractions, is opposite if we visualize it there. And we also have class 2s, which are division 1 and division 2, which relate to the inclination of these incisors. Inclination backward, class 2, division 2. Inclination forward, class 2, division 1. And well, Love's class 3 as well. Class 3 can also be symmetrical and asymmetrical. And so, 2009, when we do all the mapping, our list of problems, that's when we reach a good cross-diagnosis. Calm down, we don't finish there. Let's move on to the next step, which would be the cephalometric diagnosis. And maybe you are thinking, there is cephalometry still that important? Yes, it is very important. Look at this little one here. So we can see the characteristics of biprotrusion. And after the treatment, the change in the profile. And we can only quantify how much the profile changed significantly through this cephalometric alteration. Only you who are there, you will only be able to make a self-critique of your treatments or know what was done in the patient's mouth 2009 by doing before and after cephalometric analysis and calculating the cephalometric differences, because orthodontics can be physical, it can be art, but in the end, mathematics is what matters. To know how many degrees of change occurred in the evaluation of the incisors, how much inclination, how much protrusion, or how much alteration in the vertical direction of the patient. It is mathematics. We only know what was done with the superimposition of the profiles, or then through an evaluation in computed tomography. It does not advance the budget. Having the notion through mathematics. And of course, it is interesting that you can perform digital cephalometry, because one of the advantages is choosing the analysis that is at play. The same here. I really like the Einsteiner analysis. It is one of the analyses that I use USEND, where you can take into account some flat points, very synthetic like that. So we have here SIN, NA, NB, ND. Axis of the upper incisor, axis of the lower incisor, occlusal plane, mandibular plane, CL, psi, line H, where you can evaluate if the patient has a good maxillomandibular relationship with SIN, NI, A, and B. And we can know dental relationship, soft tissue relationship, incisor relationship. We achieve all that with the Steiner analysis. But you can use the analysis that is more favorable. And from the moment you have the cephalometric evaluations, we go to the functional diagnosis, which would basically be 5 points that I recommend you evaluate within the functional diagnosis. Use and functional suction. So, absolute suction is the first thing you should evaluate, mainly in patients who have an anterior open bite. The anterior open bite can exist in patients who are pattern 1, pattern 2, pattern 3, short face, and long face. According to scientific studies, there is no correlation between this malocclusion, which is the anterior open bite, and facial patterns. From the moment a habit exists, we can have an anterior open bite. So we need to ask, does a habit exist? When did I suck my thumb? It ends up being something we ask more for children, but also for adults. I have had and have patients age 30, 40 who suck their thumb, which is why it is important to ask in a polite and proper way, as well as to ask why the adult no longer feels very good about it. Also, always evaluate the interposition of the tongue and lips. Breathing, because there are many treatments today that we can use to improve breathing, both in preventive interceptive orthodontics and in corrective orthodontics. So all treatments with expansion, treatments that we can do specifically for obstructive apnea, like mandibular advancement devices. These devices end up being factors for improvement, and we can work together with the ENT specialist on breathing, as I already mentioned to you, and bruxism. Bruxism, something very important for us who work with orthodontics, visualizes wear, visualizes occlusal wear in children who already have their permanent teeth. We have to treat these child patients with bruxism using appliances, and also adult patients who have wear and this bruxism habit. We also need to work with options like splints, lifestyle change recommendations, and more. So evaluate bruxism, both the habit and the signs of bruxism in the patient, which are the wear, and also ask the wife, the husband, if there is noise and anything uncomfortable about these bruxisms. And finally, obstructive sleep apnea, which would be a breathing problem for the patient at night. So there are many patients today who already present pauses in breathing. And these pauses in breathing are evaluated by polysomnography, but you can already assess some signs of this decrease in airway obstruction. In the lateral cephalometric radiography itself, we have our portions of the airways, such as the nasopharynx, oropharynx, and laryngopharynx, and there you can already assess at least an indication of when there is this obstruction in the airways, and thus continue with the investigation and, if necessary, act together with the doctors regarding this non-obstructive sleep apnea. Well, dear ones, so when we do this entire diagnostic sequence, which would be the facial, occlusal, cephalometric diagnosis, and anamnesis, we manage to approach and make a problem-solving list. And if you follow this, I guarantee you will never, ever have an incorrect treatment plan, because we are studying each area of the patient in depth. I also hope that you enjoyed the video. Don't forget to subscribe to the channel and also leave a like here so that other people can view and study with this video. I send you a huge kiss, a huge hug. Bye.